Hopefully we're live on YouTube. All right, welcome. So I'm Dr. Carl Natoli,
Dr. Seth Schultz.
and we are Functional Spine and Sport out of Libertyville, Illinois, just north of Chicago. And we specialize in finding and fixing muscle adhesion and nerve entrapment. That's our main specialty. But we really do help people that have had chronic pain for longer than 6 months, have been failed by multiple providers, still just looking for answers and not sure why they're better. The majority of our consults, before a patient is established with us, we talk to them, we find out what their problems are they even a candidate for conservative care in our specialty, and the exam itself. The vast majority of the time, they have zero diagnosis. So that's a big part of what we do as well, is give people answers. So then you know what treatment and you know what steps to do going forward. So we get a lot of questions on social media, about diagnosis, about treatments, about what should I do, what exercise should I do, who should I go see? And those are great questions. They're really hard to answer when we get people from all over the world asking, and maybe we just don't have somebody to send you to, but we can give you some guidelines to go off of. So at no point is this a specific medical advice for a specific individual or treatment or condition, but it's overall general information. So at no point is a doctor-patient relationship established during these videos. But if you want to reach out and have any other questions, hopefully we can give you some guidelines to go off of and some better information there. So we took the top, what do we have here, maybe 6, 7 questions here. A couple of these have a couple different parts in there. And so we're just going to unpack these, and we would like to just do this. I don't know how often you guys want to send us questions, but we'd like to do this more often with you guys as well. So it just gets better information out there. So the better you can become your own advocate and ask better questions and challenge the status quo, the better off you will be in healthcare. That's just flat across the board. And that's why we practice the way we do, is because we saw a need for this, and just
We like helping people too.
Yeah.
I mean, we want everyone to have the knowledge going forward with whatever doctor they decide to go to ask the right questions and really search and hunt for the right diagnosis. Because like Dr. Natoli said, more times than not, patients are coming into our office with no diagnosis or a vague symptom description of plantar fasciitis or piriformis syndrome, when you really need to understand the problem. You need to be able to diagnose it first. So that's, what we do, and then we're obviously going to give you guys some answers to the questions that were asked.
Cool.
So let's get started.
You want to handle the first question?
Sure. So first one is a very good one. It's, what are the best daily exercises to do for full body maintenance? So this question, to answer this question, first you need to be, pain-free, have no massive diagnosis or massive problems with you. This is just to stay healthy, continue to stay healthy, and be smart about it. So the big exercises we do specifically for low back patients, we'll kind of work our way up the body. We do the good morning exercise. So that exercise helps strengthen and stabilize all your big low back muscles and keep your spine.
Can you see that okay? Okay.
Keeps your spine strong. The second one we do is the hip lift. This is going to help strengthen your hamstrings and keep those in a really good position.
Mm-hmm.
Third exercise is the plank. So this is going to obviously help keep your core strong, keep everything stable on the front side of your spine as well. So if you're not doing these 3 exercises and you're in really good shape and you have no pain, start doing those and see how much better you feel.
What's up? It's good.
Good.
Okay.
Good.
So we also have these videos posted on our social media pages. The one that has been going on recently, we put it all into a mashup. So it's called the 3 best exercises to prevent lower back pain. So you can go back and check through that. I think we also have them sprinkled throughout various places at some point. But you can find these online for sure. This one you may not be able to find the exact specific hip lift exercise, but again, go back and find that video. It was posted within the last couple of weeks, the 3 best exercises to prevent lower back pain, and you'll see that in there as well. So that's for the lower back.
Then we've also got, you wanna handle this one, or you want me to do the shoulder one?
You're doing great, man.
So we also have shoulder exercises, and these don't have to be complex, they don't have to be very detailed to be effective. And that's what we want with exercises we're giving our patients, is something you can do. It's easy to do at home, you just buy a couple of dumbbells and you're good to go. So the first one is an external shoulder rotation. So this one is gonna really help strengthen the shoulder cuff, keep the shoulder girdle strong, and not stress the joint out and cause unhealthy loading through that joint. And keep those muscles really strong. The next exercise we do is just a simple overhead press, right? So you don't need huge ranges of motion for this exercise, but that helps keep the shoulder stable, helps keep the shoulder strong, and you're not stressing it out in a bunch of different ranges of motion and trying to load those joints in an unhealthy manner.
Yeah, I would also add, so having some issues just stabilizing the phone there, just some other pulling movements. So whether that's a horizontal pull or a dumbbell row, just to work the back side of the rotator cuff and the back muscles. Just something simple with a rowing exercise. And you can vary the intensity, you can vary the weights, you can vary the movements, but generally you're gonna wanna do something along those lines. If you need to just hold it, just, hold it periodically. Yeah. Cool. So we won't get into the weeds too much on that. I think that's gonna cover just, again, the point of the question, I think, as far as maintenance exercises and trying to prevent problems from really stirring and causing pain. Anything else to add there?
Obviously, generally do stuff that makes your body feel good and doesn't cause pain. Listen to your body. If you're doing something and like a burpee, that's a very involved movement. You have to have a lot of stuff going right to be able to do that pain-free. So if something's not going right and it's causing unusual pain, your body doesn't want to do that, so avoid doing that. If it continues to stick around, find a doctor that can help you out.
Mm-hmm. And generally, most people are sitting a lot during the day, so with that caveat, we also want to get you up and moving around. So get up and move pretty frequently at your desk, every 10, 15, 20 minutes, even if you're just standing for a short bit and then sit back down, that's really good. So you just don't want to be sitting a long time. And then go out for a walk. And most people don't walk enough. So just get outside, especially as the weather's warming up in the Midwest here. Just get out and move. And then if something like a complex movement like that does hurt, there's always modifications and variations you can do around that to build up gradually to that. So don't be afraid to move if there's a way to work up to it. All right? Cool. Next question.
Alrighty, so this one is about a specific problem. So this person asked, they have neck pain from a whiplash accident 14 months ago, so just over a year ago. They've had physical therapy, massage, they've done some chiropractic work, but they still have significant pain. And is this something that we treat? This is like music to our ears when we read these types of questions, because these are the patients we see every single day in the office, like Dr. Natoli started the video with. The patients we see have had their problem over 6 months, that they've seen multiple different doctors, have either had a wrong diagnosis or no diagnosis at all. So,
and she also says that she didn't have any neurological deficits, so they did some testing, found out they didn't see anything neurologically or orthopedically that required further intervention, which is another good sign as far as our prognosis and our specialty. So that's tough. I mean, I feel for this lady because she's clearly not getting any better, and she's had this for a long time. She's trying, and she's probably frustrated as hell, like a lot of you are. So the biggest cause for a lot of these problems, especially after a whiplash or traumatic type of injury, is you're going to have adhesion to soft tissues. So you can imagine if you're in a car and you spring forward really fast and then snap back, that's going to just traumatically stress your soft tissues and your joints. So a couple of ways you're gonna get adhesion in your tissues, you want the green or the purple, the blue? You know, one, it's gonna come on from trauma, so like a whiplash injury or a tear in a tissue, that's gonna build up really fast, because it's gonna try to repair itself and basically guard itself almost like a cast. So that's way less common than what we normally see adhesion build up from, which is poor posture and overuse. But it happens in the same environment. This just happens really fast. Overuse and poor posture happens very slowly. Either way, it's still like glue in the tissues. It sticks everything together. It needs to move and it can't. People aren't diagnosing it. They don't know how to test for it. They don't know how to treat it. It doesn't show up on neurological testing or even MRIs unless you have a massive tear. It's going to be missed. So that's likely what this lady's struggling with. The best providers at diagnosing adhesion and nerve entrapment are going to be your integrated diagnosis providers, and you can find them on integrateddiagnosis.com, and you go to find a provider tab. That's what we do. Again, we're the top in the state, in our state, and then there's other providers around our country, Canada, Australia, that can also help with that kind of condition. So if you've had it for a very long time, it's not responding to traditional treatments, they don't know what to do with you, maybe even your imaging doesn't look that bad, that's probably your next best step.
Yep. There are answers out there, so keep looking for them and keep fighting.
Yep.
Absolutely.
Yep.
Okay.
Anything else you want to add for that question?
No.
Okay.
Yeah, I mean, this is the most common problem for muscle, nerve, and joint pain as well, is adhesion.
Yeah, arguably, we could
Yeah.
argue against degeneration
Yeah.
and osteoarthritis, but again,
Yeah.
that's gonna be, you're gonna have soft tissue changes before you're gonna have that too.
Mm-hmm.
In the rare case you have some metabolic problem or structural problem, again, we can make arguments all day,
Yep.
but this happens way more frequently than all those other things do, and it's also gonna be in combination with all those other things.
Yep.
Yeah.
So we're good there.
Cool. Next question was a patient with Ehlers-Danlos. So abbreviated, Ehlers-Danlos Syndrome is a connective tissue disorder. We're just gonna abbreviate EDS to get through just saying that too many times. But basically EDS affects the collagen, so your connective tissue, and it can range on a spectrum. So, you know, you may, let's see, on a 0 to 100 spectrum of this disorder, 0 you're gonna have, well, you know, this is effectively not nothing, it's just the lowest end of EDS, you know. So 0 is not effectively 0, it's just 0 for EDS.
Mild.
Yeah, exactly, mild. This is gonna mean you're a little bit more hyperflexible, maybe you have some joint pain starting at an earlier age, but you notice you have just really big ranges, almost like a dancer or a gymnast, but you've never had to train for that range of motion, it just naturally happens.
Mm-hmm.
On the far end, it's gonna be affecting your collagen and your connective tissue so badly that even your blood vessels don't work very well. So like it's so severe that things just can't form enough to hold structure. And that can even fail cartilage and discs and all sorts of stuff. Like I said, blood vessels and other fascial connections, it's just really nasty. So this we would never see in our office. This we would see up to a certain point, and then it gets to be so poor responding to manual treatment that it just doesn't hold.
Mm-hmm.
But basically someone on this end, I think the question was, you know, do
Can
you
we
see
help?
that?
Yeah.
Can we help? And
Yeah.
yeah, if it's on the very mild end, we're still gonna test for our typical ranges of motion and tests and all the normal things we would do to test for any soft tissue problems, or at least a suspicion of it being there, and then put that into context with that patient. So a perfect example would be a straight leg test. So
Mm-hmm.
90 degrees would be good range, you know, perfect range and for that instance. And so maybe this person has, you know, they're healthy, might be 120 degrees, but they come in and it's like at 100 degrees. You know, you can still look at that without knowing anything about this person and say, well, that's a good range, we don't even need to bother with it. But maybe in the history that's what produced symptoms. Maybe the other side is at 120 and the bad side is at 100. So we're gonna take that and put it into context and then just feel the tissue and see what's going on there. So if it can still be treated and still unloaded by finding or reducing any soft tissue adhesions or nerve entrapments, they're gonna respond a little bit better. And then we just check and manage and monitor any structural damage, exercise,
Strengthen any
activity
tissues
modifications.
need to strengthen.
So basically, we try to stabilize that cartilage and the discs and all the other structural problems to keep it from becoming an orthopedic problem. But generally, we're overlapping with orthopedics in this type of realm with patients anyway.
Yeah.
Cool?
Yeah, so in short, do we help with EDS? It depends on how much adhesion we find and other issues along
On
the
the
spectrum. Yep,
You got it.
100%. Next question. This one was more related to exercises and, you know, which is better, extension or hyperextension for shoulders, and then the low back.
So, yeah, so it was a bit hard to understand, so I tried to specify with this person. It sounded like they were curious about shoulders. So, yeah, they were saying, okay, well, should I go, and I think they were talking about a lateral raise or a front raise. So if you're doing an exercise with a dumbbell, 25 pounds, you're doing some lateral raises or side raises, should you go all the way through a full range of motion? And again, I would err on the side of don't do that. One, if you get into the physics of it a little bit, it's a longer lever arm. It's gonna stress the tendon and the joint a little bit more than if we're just pressing straight up or only going up to a certain position and stopping. So you run the risk of losing the benefit of the exercise and increasing the risk
Of an injury.
by going through some bigger ranges that you don't need to go through. So, if you're doing some raises, you're fine to stop at 90 degrees and something that's comfortable, challenging, but not painful, obviously. And then if you wanna go up, just go straight up. If you wanna go back, go straight back, unless you're doing like a bent, fly, reverse fly. So, yeah. we
Yeah,
go from there
yeah, and then,
as far as the back.
and then for the back, you know, you see a lot of people wanting to strengthen the erector muscles with big hyperextension exercises, and what we generally go off of is you wanna strengthen in a neutral position. So that good morning exercise we talked about earlier in the video, that's a perfect exercise to strengthen your low back muscles. You don't need any massive extension to create strength, because what you actually end up doing is pinching the joints in your back and, you know, starting to create unwanted stress on those joints, which would lead to early signs of degeneration or arthritis, which none of us want to start that process early.
Stress reaction, stress fracture, yeah.
Yeah, and even if you have an underlying disc problem that hasn't showed up symptomatic or painful for you yet, and you start extending back on that, it actually pinches back on the disc, will create inflammation and create pain that way too. So rule of thumb there, strengthen in a neutral position, do your good mornings, don't worry about extension.
Yeah, because you're gonna get plenty of bending, twisting, loading throughout just daily activities. So you're better off strengthening a neutral posture, so when you go to do those things, your body can handle it, and it's like, yeah, this is nothing, no insult. So yeah, I mean, in a perfect example that we were talking about earlier with extension, hyperextension especially, is that when we're seeing gymnasts, wrestlers, ballet dancers, they're constantly going into hyperextension, where they show up with early onset osteoarthritis in their facets, disc injuries, and stress fractures.
Yep.
So, should you load in hyperextension for everyday people?
No.
Hell no. So, strengthen and neutral, your body will thank you in another 10, 15, 20 years, it'll certainly thank you more.
Absolutely.
Yeah.
Absolutely. Next question, what's the difference between manual adhesion release, which is what we treat in our office, or how we treat in our office, and Rolfing techniques or other soft tissue techniques which also claim to release adhesion?
Bit of a loaded question.
Absolutely.
And it's certainly very nuanced, so if you're a provider watching this and you take offense to it, don't. You can always just reach out to us, but we'll get into some of the specifics on that. So MAR, we'll shorten that, manual adhesion release, that's what we do. You know, the specific thing is that it fixes muscle adhesion and nerve entrapment. And we don't treat general healthy tissue, we don't treat structures, we don't treat trigger points, hypertonicity, any of that. Because that's just a sign of something or a symptom of something, it's not a cause. So we can test for adhesion and nerve entrapment through very specific tests that suggest that it's there, and then find it with our hands, and then when we reduce it, those tests get better, the symptoms get better, and it goes away and we can feel the changes happen. So that's the kind of the general process of that. The other soft tissue techniques I haven't come across, and I used to do a lot of them, I haven't come across any of them that go through a process of diagnosing or testing for adhesion or nerve entrapment specifically, or differentiate the difference between a structure, say fascia or a muscle, and then within that structure, adhesion versus hypertonicity versus inflammation versus trigger point.
Yep.
So, and as far as a patient is concerned, if you're watching this, the general guideline there is if you're getting one of those things done and you're not being tested or measured for it pre and post, and if you're not being tested at all, you need something different. If you're being tested but it's not sustainably changing, especially within 4 weeks, that treatment's not specifically for your problem. That's the easiest way to look at it.
Yeah.
Yeah.
Yep.
Cool.
Yeah, that was a great answer there.
Okay.
Next one and our final one. This is a little longer one, so we'll spend a few minutes unpacking this one and answering it fully. So, once you release adhesion using manual adhesion release, do those adhesions ever return? Does it depend on your lifestyle and activities that can bring on the same adhesions in the body? So that's a really great question. And
High level question.
Very high level, and this person is just thinking much further than lay people typically do.
Yeah,
when
usually it's
they
just getting out of
hear
pain and
this,
that's
yeah,
it.
absolutely. So, to answer the first part, does adhesion return? Again, that's going to be on a spectrum depending on your age and then any other underlying diagnosis that you may present with. So for simplicity's sake, if you're a 25-year-old adult, you're relatively healthy, and your only problem is adhesion, once the adhesion is gone and you don't return to the activities that built the pain to start or built the adhesion to start, it will stay gone for a very long time. It's hard to put a number on it, but you'll be pain-free until the adhesion builds back up. It could be 3 years, it could be 5 years. It all depends on how you're stressing your body and what things you're doing on a day-to-day basis to
Right.
stay healthy.
So this is another way to look at it, just graphically, right? So if you're, say your pain line is here after you do so much or just cumulatively, and you're 25 and it's only adhesion by the time you start noticing symptoms, if you reduce all the adhesion, you're gonna be back to baseline, 0, right? From there, it's like you can think of it 2 ways. I think the easiest way to think about it is like a bank account, right? So now, if you're at 0 symptoms, you have a bank account of $100. Let's say it's simple. Every time you do something, whether it's sit on your phone for hours a day at night, or studying for exams, and you're sitting like this all the time, or you like to just go crazy at CrossFit or run 100 miles a week, every time you do something that your body hates you for, you detract or subtract from your bank account. Some of that you can build back up with the right rest and recovery and proper nutrition, sleep, and there's a lot of details with that we won't get into. However, if you're not doing those things and you're continuing to subtract from that bank account, over time, this problem will build up again until it flares and rears its head again. And each time you go through this painful cycle like this and you're getting older, you're gonna start to run the risk of structural damage. So I think that's probably the easiest way to look at it from a young, one diagnosis point of view.
Simple.
Right.
Yep.
So let's say this person's now 50, and they have adhesion, but they also have degeneration in their lower back. Now this graph is going to look a little bit different, although the concepts still stay the same. So let's say it's 50-50. This part doesn't go away. This part will unload this and help it get a ton better and bring this person below pain threshold. But the concept still stays true, they're just gonna have to be a lot smarter with their decisions and protect that bank account tighter, okay? And invest more into that, so whether that's doing more diligent rehab, or, you know, really working on modifying how, you know, instead of, as weather gets nice, I'm gonna go out and clean the entire yard in a day, and it's gonna take 12 hours, and it doesn't matter what happens, I'm gonna get it done, you're gonna be jacked up. So just being smart about every daily activities will help you invest more into this account and save this for both of these conditions from worsening. So, does that clarify some of that, you think?
I think so, and I think just to go on this caveat a little bit, if you have degeneration block like this and a bunch of adhesion on top of that, what will happen if you don't get adhesion treated and put in the proper context and your activity dialed in? This box will get bigger. So this isn't as big as it's gonna get, it will slowly get bigger. So the longer you wait and the longer you live with pain and don't get a true diagnosis or find a doctor that can really figure this out for you, this box is just growing and growing and growing until one day you could potentially be a bit above that pain threshold.
Yeah, and sometimes that's not the person's fault. Sometimes what we've seen is that the provider will tell them, go ahead and do whatever you want, it's below pain threshold, just do the same thing that basically brought you in the office. And that's foolish too, and that's not fair to the patient, because then they show up with the worst problem and they don't know why, and then they're pissed and frustrated, clearly. I mean, I would be too.
Yeah.
If someone said, no, you're fine, go ahead and do whatever you want,
Keep
and then
doing
I
what
came
you
back
wanna do.
with something worse.
Yeah.
So just be aware that that can happen too.
Yeah, like you wouldn't keep driving your car with the check engine light on. You're not gonna keep doing the same thing on your body with your body's check engine light coming on. So
Yeah.
listen. There's answers out there for pretty much everything that we come across.
Yeah.
And
And I think in the second part of that is, you know, does the
lifestyle
adhesion
activity.
come back? So that kind of covers the yes, but part of that, or yes,
Mhm.
and.
Mhm.
This covers some of the caveats of that. The other way you can tell is if you start becoming less flexible, despite rolling, stretching, yoga, doing those rehab exercises, and things start to nag at you again, like maybe it's only a little bit during certain parts of the day or after certain activities, and then it starts to creep into more activities of your life, that's a sign that the adhesion's starting to build up again.
Mhm.
So those are early indicators. It doesn't have, you don't have to wait till it just blows up and the wheels fall off and you're like, yeah, I'm not doing anything anymore. So just be aware that those are early indicators of that soft tissue becoming a problem again.
This, you know, when the adhesion's small, it's easier to treat. So if you can be aware of that, you're gonna get better faster.
Yeah.
Yeah.
Small problem to fix is always way faster and way better prognosis than a large problem with a lot of layers to it, which is generally where people are by the time they see us.
Yeah.
But that's just the nature of our specialty and our niche, so.
Yeah.
That's it.
Yeah, this was, thank you for being patient with us at the start. This is obviously our first time. We want to do more of these, so you guys just keep coming with your questions. You know, if it's something that you've been wanting to know about for a long time and no one's really given you a direct answer, we are happy to answer questions that you guys have. Even the Ehlers-Danlos Syndrome, that's something we don't typically see.
Yeah, less than 1%.
Less than 1%, but we still did our research on it because we want to bring this information to you guys so you can have it readily available whenever you need it. or
Yeah,
want it.
and if you need a referral, you know, reach out to us. We do know all the integrated diagnosis providers that are certified, that do know all of this information and can provide the results. So reach out to us if you need help there.
Yeah. All right.
Thanks a lot.
Thanks for watching.
See you next time.